Okay, so while we have we are near a quorum already, but as people continue to join, I'd just like to welcome everybody to our Friday CFAR conference. In terms of schedule, next week we'll have a case discussion, so please join us for that. And then we have an August recess. And then when we come back in September, we'll start off with a review of what the AIDS 2024 meeting in Germany next week, and then have some other exciting topics planned for the fall. So today we have a hepatitis B extravaganza, which is led by many people from our hepatitis B group here. But Sherilyn, I think you were the organizer of who rallied together all these troops, and we have Lee Gilman, we have Mark Sulkowski, Dave Thomas, and I think Chloe's joining too, right? And she may still be in clinic. But I will turn it over to them so that we can get the latest updates on hepatitis B.
Well, great. So I will, on behalf of the group, so what we did is pull together some cases, because I think Hep B lends itself to case discussion and teaching. And I agreed to kind of walk through the cases and then call on, I guess, pretty much everyone you see with their camera on. And I'm looking to see if Chloe is hiding somewhere, but she is transitioning from the Bartlett Clinic. But we'll certainly pull her in when we see her arrive. So the goal will be to walk through these. I am not as talented as Michael Amelia at setting up voting. So there'll be some questions that look like opportunities to vote, but I'm just going to ask our panel to vote. But really feel free to sort of unmute and chime in, and certainly ask questions along the way. This is meant to be very interactive. All right, so let me see if I can share. And then hopefully you all can see my screen. It just should have a
Yep, looks great.
kit. Perfect. I found this new dome template, which I incorporated. So let me jump into the first case. A 6-year-old man born in West Africa, newly diagnosed with hepatitis. No prior testing. He requested the testing after his sister was diagnosed. Unaware of his mother's Hep B status. At his diagnosis, his virus level was 7,900. He was E antigen negative, ALT of 32, no liver disease, negative for C and HIV, and he had a liver ultrasound, which are remarkable. I measured a hepatitis B quant, how much S antigen was present, and I'm going to stop there and ask our panel to weigh in on, this is a relatively new test. It took, I think Sherilyn worked for about 2.5 to 4 years to get it added to Epic so we can order it, but it is orderable. When you type in S antigen, you'll get a quant and you'll get a regular S antigen. This is not for diagnosis, but let me ask, are you all measuring quantitative S antigen on your patients? I see Dave shaking his head. Do you want to expand on that, Dave?
Just kidding. Yeah, I am Mark. So the hepatitis B quant antigen test, the most valid use of that test is to predict the ability to stop treatment, and so you could ask why do it at baseline, and I think we all believe that there'll be expanded uses in the future to guide, and knowing where someone begins is useful. But to reiterate, the most valid use is to determine in whom you can stop treatment with tests of sort of less than 10 and certainly less than 100 being necessary to have a high likelihood of stopping treatment without hepatitis B relapse. The other potential use, and there's been some data to suggest that people with higher levels have higher risks of hepatocellular carcinoma. And so that's another possible sort of, if you're on the fence for screening, it can be possibly useful in that measure. But in this guy, the tough thing is he's sort of in the gray zone. No obvious liver disease, viral loads that are sort of in the in the lowish range, and so the treatment decisions in him will be harder. But that's my thoughts on the quant.
Let's see if anyone else has any comments to add. So I guess I think of it simplistically as to lower that number. If the goal is to get to 0 S antigen detectable in the blood, the lower that number is, the closer to a not detected, the closer you are to what we call functional cure, a loss of S antigen. And he's not that close.
Yeah, no, he's not that close. And it's also useful maybe to frame that there's two places surface antigen can come from. One is DNA that's integrated into the nucleus, and then the other is the CCC DNA. And so those two sources are both important. And the relative abundance of whether it's from one or the other may end up being important. And Chloe and Ashwin have really been the international leaders in sort of dissecting that dynamic. So it's just worth mentioning that as well for sort of people that want to delve deeper into how that test might be informative, but not so much clinically.
Yeah, and we can't tell from the blood test where it's coming from, but Ashwin and Chloe are going to figure that out for us at some point. It's a necessary test. So let me go on, and I wanted to ask if folks would test him for hepatitis D virus. Are people routinely testing for D? Let me say maybe a show of hands from our hepatitis panelists. Are people routinely testing folks for D? So most people routine voting. And like I said, I'm not sophisticated enough to sort of do a polling question. I wish I were, but I'm simply not. So I did want to just quickly review some of the current recommendations. In Europe and WHO, they say screen everybody with B for D. Delta is a satellite virus that occurs only in people with B. The US, which is the American Association of Study of Liver Disease, is a little bit more complicated. You'll see they recommend screening people at high risk, and the list looks like this over to the right. So people who have ever injected drugs, men of sex with men are certainly on this list, people with multiple sexual partners, and people with HIV. He was born in West Africa where there's a high prevalence. So he would get screened. But I will say, I think the US is moving towards test everybody. So this is a question that I wanted to highlight the idea that in Hep B, we don't necessarily treat everyone. So would people treat him? He had a viral load of 7,900, an ALT of 32. So maybe I'll ask someone to, maybe I'll ask Sherilyn to comment. His ALT is sort of normal. His viral load is 7,900. Would you treat? And if so, how?
So I would probably ask you that question, Mark, if I was in the clinic. But so yeah, it is a little gray because what I tend to look at is the magnitude of the Hep B DNA based on guidelines. It's usually a cutoff of 2,000, and the serum ALT, and his ALT looks normal, and I guess it depends on what you're using as a normal range, but it's sort of still upper limit of normal. I think the thing I worry most about is he does have replicating virus that's sort of above that cutoff. It's not particularly high, but it's but I don't like that mom's history of cancer. That is really not something I'm comfortable with. We don't know what cancer it was or whether or not she had hepatitis B. But in the background, in someone who's older and from West Africa, you worry because with liver cancer in the setting of Hep B, it can manifest anytime. And so I think that's something I'm concerned about. I don't like that. So I would be inclined to want to treat him, even though based on his pure numbers, I guess the other approach is you could repeat things. But again, he's probably had this. My guess would be long-term, potentially lifelong.
So leading towards treatment, although Dave had mentioned he's in the gray zone, which is that kind of, as you nicely described. Ashwin, I see your hand up. Do you want to comment, or is that residual hand up?
Residual hand, sorry.
Well, feel free to comment. But so maybe I'll have a vote. Who would put this patient on treatment? And I'm putting our panel on of votes. I'll count them up. I can definitely count the number. Actually, I'm counting you, by the way, because your hand is still up. So I've got maybe 3.5-ish. Juhi, you would not treat him? What would you do?
Yeah, I wasn't even thinking. I was just thinking the family history of cancer, maybe because that would change your screening, maybe your HCC screening guidelines. But I feel like he has a high viral load, but no fibrosis, normal kind of LFTs. It's kind of that mutual shared decision-making world that you do with the patient about whether to start or not, and what the endpoint is, if there is any endpoint. I probably would not have put him on any treatment.
Yeah, I don't want to
And
highlight.
Mark, I just want to agree. Like I was raising my hand, but I want to agree with Juhi. I think these gray zone ones come down often to the patient and things like how much it costs them for the medicine and what they're, because one thing you can say is this guy's going to be committed for a long time with that high surface antigen level. You're not looking at cure. And so, you know, you have to say to him, the things I know for sure are that we can do a pre-approval, find out what your costs are going to be. And then I think it's possible that I'll reduce your liver cancer risk, but I'm not 100% sure about that. And I think it's nearly impossible that you're going to come off in the foreseeable future. So, the other positive I usually add is that I think it's possible that by starting now, if there is a cure, I might have you a nudge closer to that in the future. And then I find people make different decisions with that same information. So I agree completely with Juhi.
Yeah, and I guess I'll just underscore this. In Hep C, it's if we have detectable virus, we treat. HIV, we treat. In Hep B, there's a lack of evidence, even good prospective cohort evidence about treatment of this kind of what we call gray zone. So people with HIV, the recommendation is treat everybody. They all get a tenofovir-based antiretroviral. People with cirrhosis, we treat everybody. But if not, we look at the ALT and the viral load. I'm going to jump ahead. There is a push by the WHO to really expand the number of people on treatment. And one of the reasons is there's not a lot of people on treatment yet. So they're looking at a viral load of any cirrhosis or fibrosis more than F2, any presence of co-infection, that's number 3, and viral load greater than 2,000 ALT, upper limit normal. So by that, he might start to get into the range of treatment. But I wanted to highlight there's just this push to try to get more people on treatment because globally, very few people are actually on treatment. And then I'll just comment, if without HIV, the recommended treatments are really here, tenofovir or TAF plus entecavir. That's really all we have. So I'm going to jump ahead. Okay, should he start surveillance for liver cancer? Maybe I'll ask Lee, would you start him on surveillance for liver cancer, and what would you do?
I absolutely would, and as other people have suggested, that the concerning nature of the mother with some sort of unclear history of cancer, we know that unlike in hepatitis C, where only people with advanced cirrhosis or advanced fibrosis or cirrhosis have a higher risk for hepatocellular carcinoma. Those with chronic hepatitis B have an increased risk for hepatocellular carcinoma at any stage compared to the general population. And I think you have this on the next slide, but an approach with a combination of both ultrasound and serum AFP has shown to be the most sensitive for screening for hepatocellular carcinoma.
That was perfect. Let's go to that next slide. So there is a guideline of who to screen, and it's based on the risk that someone might develop liver cancer. So for people with cirrhosis, whether it's from Hep B, Hep C, alcohol, or non-alcohol related steatohepatitis, there's supposed to be screening. For hepatitis B, it's a little more complicated for the non-cirrhotics, as Lee was alluding to, but men greater than 40, women greater than 50, potentially persons from Africa at an earlier age, family history. So people were focused on that a bit earlier. And then they did endorse AFP. AFP has been in and out, but it's not AFP by itself. It's ultrasound plus AFP, because not all hepatocellular carcinomas make AFP. But I want to ask Chloe, do people with HIV need screening at any stage? They don't list it in the ASLD guidelines, but what about the OI guidelines?
Yeah, oh, my phone's ringing, so just ignore that.
Great timing.
Yeah, so it's a good question. We do know from several studies now that HIV does increase the risk of having HCC. So I think that the recommendation is to screen people with HIV for HCC, regardless of whether or not they meet one of those risk factors.
So I didn't pull a slide, but there are a number of studies suggesting that in a lot of different patient populations, including people with HIV, we do a lousy job of screening. It's ultrasound every 6 months, AFP and blood work every 6 months. Dave, I know you've been trying to tweak the EPIC people to kind of move this along. What can we do to kind of get this on the radar to help people remember, both the patients remember that they should be screened, and also our clinicians? And it's hard. It really is hard. I'm not trying to minimize that, but you've been trying to tweak the EPIC folks to do this.
Yeah, I don't know, Mark. I think I think the providers, at least the hepatitis providers, and when I happen to see one of someone else's patients, it's usually that we have mentioned it in the visit. So I think it's the hard thing is getting somebody with an asymptomatic condition to bother with something like ultrasound. And I don't know. What I want is for the EPIC to produce letters every 6 months reminding folks, and we should be able to just put them on that registry, and they should get those letters. But I'm not sure what's the best motivator. I think that honestly, one of the things that seems to happen is people get confused about FibroScan sometimes and thinking that's an ultrasound. But I don't know, Mark. I don't know what motivates folks to do it. I think it's a real hard issue.
Yeah, I don't have an easy answer. I don't know if others do, but trying to ultrasound surveillance, and the idea behind surveillance is that we can identify a liver tumor while it's small, and if it's small, we can have options for people to get resection surgically or microwave ablation in radiology, which is really actually surprisingly easy if they can reach it. Or even liver transplant, which of course the Hopkins group does offer to people with HIV. So that's the idea. It's a similar rationale to mammogram. So I'll move on. And this is a 48-year-old man who's on a bictegravir-based regimen. He wants to switch to a extended release injectable. And he is HIV is not detected. His current blood work shows no markers are positive Hep B. He was vaccinated about 15 years ago when he first presented with HIV, but it's not known if he responded. But he doesn't have anti-HBs now. So I want to talk just a little bit about vaccination. So how would folks vaccinate him? And maybe I'll go back to Juhi and just ask her what you're doing in the Bartlett Clinic for Hep B vaccination for non-immune people.
I've been using the new Heplisav. I feel like it's the most effective. It's only a couple shots. People don't miss the follow-up appointments. With some of these 3-dose regimens, they always forget the last one, and you have to play catch up a year later or something like that. But before that, I used to do the double dose, which was 1, and then now I do the 2-dose. Is there even a 3-dose? I see it's written there. Is there even?
So actually, I'll talk about the study that was done called the Beehive study in ACTG. They used 3 doses in people with HIV. Whether or not you can get it paid for is unclear. I'll go to that study. So part of the reason I put that in is that we do have hepatitis A/B in Bartlett, and there was a really nice study led by the ACTG that looked at this. The hepatitis A/B is this Hep B CPG, and they did a randomized controlled trial. And what the data show is that it was much more effective. And when you got a little bit more response with 3 doses, although 2 doses was really pretty darn good. So this is something that I think is moving towards the standard of care for people with HIV. This is the non-responders. They've also presented the naive to vaccine. It was also better than the standard vaccine. So pretty easy to do in Bartlett. I have found it hard to do if you're trying to do vaccine through pharmacies. Anyone want to comment on the hepatitis A/B vaccine and kind of where it fits?
Yeah, I'll comment, Mark. So yeah, I agree with the hepatitis B vaccine based on these data. The other thing that I'll say in the updated DHS guidelines that will hopefully be coming out soon, what we said is that people who have been vaccinated in the past with the standard Engerix B and have failed should get the 2 dose, and the 3 dose should be considered, because in that group, as you can see here in that bottom left graph, that group really does better in terms of the titers, not the number of people that responded, because that was pretty much the same. But if you look at the different shadings, the people with the 3 dose vaccine were much more likely to get greater than 100 in terms of their surface antibody titers. And we just think that will last longer in terms of durability of response. And the other point is that they are doing additional analyses. I've spoken with some of the investigators in this to see if they can really make a stronger case for 3 doses in this situation. The data seem to trend that way. They say they hadn't finished the analysis when I talked to them about it. But so the guidelines will say, everyone should get a 2 dose, and 3 dose should be considered for these reasons of higher antibody titers.
That's great. Can I ask a question about, so part of it, he's been on tenofovir, and does that protect, but he was not immune to Hep B. Did the tenofovir protect him from acquiring HIV?
You mean from hepatitis B?
Yeah, I'm sorry, Hep B. I'm sorry, I misspoke that. Thanks for correcting it. So
it will protect him from HIV.
Yeah. Well, actually, lenacapavir seems to work better, but
yeah, but that's
anyway,
a different point.
well, that's a different case conference. We'll leave that one alone. But yeah, did the tenofovir help protect him? Let's say he had partners who would Hep B infected. Would the tenofovir have protected him over time? And now that he's coming off that, is he no longer protected? Unless
so it definitely protects him. It definitely helps reduce the risk of getting infected with hepatitis B. It's not 100%, and the reason is because the way tenofovir works late in the life cycle of hepatitis B, so you can still actually get the initial infection, but it certainly reduces the risk dramatically that he'll get infected. And if he does get infected, it would almost certainly help him shift towards recovery as opposed to chronic hepatitis B.
So part of the reason why I wanted to just talk a bit about that, in people presenting for PrEP, that is HIV prevention, really important to give the Hep B vaccine if they're not immune, to work that up, screen for STIs, Hep C, Hep B, and then vaccinate if non-immune. I've actually seen one patient in the past who acquired Hep B, who really was just missed an opportunity to vaccinate, who was an older individual. So I'm going to go on.
Mark, can I just make one more quick comment
sure.
about hepatitis B?
Yeah, I can see you on there, Andrew. Thank you.
Yeah, well, I was late coming out of a lecture. I was giving it home when I'm in the car. So, but I was actually, I just want to point out that the data on the study show the traditional risk factors for non-response to vaccines. So if you're contemplating 3rd doses, think about other risk factors for non-response, like you have age on there, but also male sex, obesity, low CD4 count, that is, so I think also we can exercise some judgment, and in people who are likely to be non-responders because of obesity, being male, being older, those are actually more dominant than HIV if you have a high CD4 count, and I would give a third dose then.
That's a great point.
Mark, can I ask, just clarifying, so with the 2-dose Heplisav-B, you give a dose and then you give a second dose a month later. With a 3-dose option, is that a third dose the following month? How was that studied?
It was given 6 months later as the 3-dose Endrex-B series is given.
Okay.
Yeah, it matched the standard. And the company had studied this in people on dialysis, another group that doesn't respond as effectively to vaccine. So
Yeah,
I think
listed dialysis or people on other forms of immunosuppression. Those are other risk factors you raise.
Yeah, that's great. And I will say the vaccine is a little bit more expensive than the standard, but they've actually done cost effectiveness models since very few people actually get that third dose. 2 doses for a vaccine naive person is much more cost effective because people actually can get it. So I'm going to go on to the same case, but this person is core antibody positive, can't recall if he was vaccinated, and doesn't recall ever having acute hepatitis. So the question is, can this individual who's core antibody positive come off tenofovir and emtricitabine and go to a tenofovir sparing regimen? And a corollary to this is, would you vaccinate him while you're doing that? So does he need Hep B therapy? What would you do? How would you handle this? This question's coming up actually quite a bit. The other scenario, it may not be cabrylpivirine. It might be 3TC dolutegravir is another one where it comes up. So what do you need to do with this person as you contemplate removing Hep B active ARVs? So I should warn Dave that I see you shake your head, I'm going to call on you.
Mark knows it's good to call on me when there's no data, because that's never really a bother for me. I think there's a couple of things that are important here. First of all, that we have very limited data on. I'm not aware of much data to inform this decision, both on a couple levels. One, because people with anti-core who are positive were excluded from the trials of the switch off of the Hep B active regimens to the long acting. So we don't have in the big registration trials, we don't have much data to inform the denominator, the safety. What we know is that there are numerator data. There are instances of hepatitis B relapse in people who were core positive, who were switched, and we in some instances aren't even sure whether those are new Hep B infections or whether they actually represent relapse. So then that takes us to the question of, is there value in immunizing or in vaccinating somebody with anticore only, with or without this switch anticipated? And I just, in a private text to Chloe, confirmed that there are no data that to really inform that decision either. But I think common sense tells you that if the Heplisav-B vaccine boosts immunity better in persons who are on dialysis and persons who have HIV, and materially improves seroconversion, then it probably does in the isolated core situation as well. So it stands to reason in this case that I would vaccinate, check anti-S after the vaccination, and whether or not I would switch would have to do with the relative imperative to switch in terms of the person's really wanting to, really needing to, and then you can just monitor with Hep B DNA levels for a bit afterwards to make sure that it was a safe decision.
Well, thanks for that. Two corollary questions. Would folks order a Hep B DNA in this person? So I'm seeing I'll see a show of hands. I've got well, I've got a lot of people leading up to Chloe who did not raise her hand on HBV DNA. So, but everyone else I think did. So Chloe, what would you do? Would you order the DNA, and and how would you use that if we got it?
Yeah, I would order it. I just didn't raise my hand.
Okay,
I would definitely order it if I was gonna switch him to something like capylpivirine. I mean, for a couple of reasons. There are some people with, true occult hepatitis B that have isolated core antibody, meaning that they have hepatitis B DNA, so active chronic hepatitis B, despite not having surface antigen. And that actually can come about, interestingly, for a couple of reasons. Surface antigen can be negative because, interestingly, there are mutations in the surface antigen that can cause some of the tests to be negative when really they have a positive surface antigen. We actually had a case that we published with the renal folks of a patient on dialysis who at our Hopkins lab was repeatedly surface antigen negative, ended up getting hospitalized at University of Maryland, and they tested her surface antigen there and it was positive, super high DNA levels, like in the millions. We actually had that blood tested here again, and it was surface antigen negative. It was just simply because of the test that was used here didn't capture a mutation that she had in her her hepatitis B virus. So it is possible, so although rare, but I would get the hepatitis B DNA.
So the man is pointing out that he's on tenofovir, so it might have been helpful, but you would check it after the.
Oh yeah, this person's on tenofovir. You're right. If they're not on tenofovir, I definitely would. On tenofovir, I probably.
Well, you would check if you made the switch. You check maybe a month later.
Yeah.
And I think Dave mentioned that. So what about lamivudine, dolutegravir? Would people feel lamivudine does have anti-HBV activity? There's a high breakthrough, so we don't use it as monotherapy. But would that be a bit safer in this group?
I would say if they were DNA negative, I would say it would be a bit safer. But as Dave said, I would still explore the reasons they, wanted to switch before making that switch. I would still feel more comfortable being on a tenofovir-based regimen.
And Chloe, in the chat, a follow-up question from Jeff Tornheim. What those occult B people, or those people, would they have elevated ALTs, or how does the ALT help you in knowing that maybe they're replicating?
Yeah, so in most of the studies where people have occult hepatitis B, the DNA levels are actually quite low, as you could imagine, because the surface antigen isn't there. That this oddity of a surface antigen mutation is rare. So most of the studies, the DNA levels are very low, in the 100 to a few hundred at the most. And so you won't necessarily have that much of an inflammatory response in the liver.
Yeah, so ALT turns out to be sort of a challenging test in that it can be relatively normal with hepatitis. Actually, there's several phases of hepatitis where you really don't get a lot of inflammation. Well, let me jump ahead.
Mark, could I just ask a quick clarifying question there?
Oh, sure. Absolutely.
So that was great for isolated anticore. So what if you have positive anticore and anti-surface and negative antigen and DNA? Do you treat that the same or differently, and following surface titers and boosting, or?
So I want to make sure I got that scenario. You're saying that they're core positive, but surface positive too. They're already as positive.
Right, but no signs of disease. So they could have been an isolated core who got vaccinated, or that could be more proximate evidence of actually having had Hep B. I mean, I found a couple of these people in like Triumeq, dolutegravir, bacavir, 3TC on the 3TC, but like as I go to switch them, I pay more attention to these things. But I just wanted to know if people treat that differently or treat that the same.
Yeah, that's a great nuance. I'll let see if there's a volunteer to dig into that one.
I can volunteer. Yeah, so Eileen, I would treat it differently. I mean, that person clearly has a good immune response to their hepatitis B. And I think that especially someone who's also on 3TC, I wouldn't have any hesitation switching to that. I would also give them long-acting CAB, rilpivirine, unless they get immunosuppressed and lose their surface antibody, then they're unlikely to reactivate their hepatitis B. But that's my opinion. I don't know if other people have other opinions.
So, Chloe, I wanted to ask you about the sort of reactivation situation where at least does because this is sort of similar to reactivation in a way. Does the anti-HBS make a difference in terms of Hep B waking up? So Dave is saying you check a titer.
Yeah, so the guidelines on reactivation with immunosuppressive therapy, so with anti CD20 therapy or severe immunosuppression for cancer or some other immunological condition, doesn't distinguish between surface antibody positive or negative. Their guidelines really are just surface antigen positive, negative, core antibody positive, negative, and that's all that's in there. And they actually make a point and say that there aren't really data to show that good data, I guess I should say, to show that how much protection surface antibody gives you if you get immunosuppressed. And that's, especially you could imagine with the anti-B cell antibodies, that if you have surface antibody, if you're then deplete their B cells, that surface antibody might go away. And so in that situation, I think whether or not you have surface antibody at the time probably is not that relevant. I will say that I have seen some small studies where they do the titer of surface antibody, and people whose titers are higher, I can't remember what the cutoffs are, if it's 500 or 1,000, I can't remember what the cutoff is for surface antibody titer, but people with higher titers are less likely to reactivate. But there aren't enough studies to know what that titer is.
So that gets back to, I think Dave had started off this discussion by saying that for the core positive only person to go ahead and vaccinate just to try to get those titers up. And Dave, you mentioned checking a titer. Our lab doesn't routinely report a titer with anti-HBS. So maybe you could talk about that a little more.
Yeah, that's a technical challenge. I think the studies, I mean, for Eileen's situation, if somebody's got a titer of 11 versus a titer of 511, then I feel differently, and that's all. I was just you'd have to, I think, get it from, is it LabCorp that does it, where you have to actually order the titer, but it's but yeah, I think it's also the decay rate is predictable, and so if you have a titer just barely over the cutoff, then I think we'd all be a little bit more nervous and perhaps even boost in someone switching off compared to somebody who has a really high titer. So that's all.
Great. I was hoping you'd tell me how to order one, because I've actually not been able to find it to get it ordered in Epic. So I was hoping you had like a solution, but maybe someone can we can offline figure that one out. All right, I'm going to jump ahead and oops. Let's see. So this gets into the question of reactivation. This is a person with prior Hep C who was cured of Hep C and prior hepatitis B, as he's antigen negative, S antibody negative, but he's core positive and HBV DNA is not detected. So it gets to this question that Chloe was talking about with reactivation. So I guess the question I'll just ask the group is, would you give him prophylaxis? Or how would you manage this? Chloe, you talked about the titer being negative, but would he get prophylaxis starting anti-TNF therapy, or maybe let's say rituximab if you want to use a different one? But what's his risk of flare and how would he handle that?
So we'll just start with anti-TNF since that's what it says. So the guidelines divide the risk of reactivation into high, moderate, and low. And so anti-TNF would actually fit in the moderate. High is greater than 10% risk. Moderate, I think, is 1 to 10%, and then low is less than 1%. So the anti-TNF would actually sit in the moderate category, and the recommendation there is to prophylax with some caveats, and basically the caveats are whether or not the person, would take the medication, whether or not they want to take the medication. Some people don't want another medication, if they're on 1 million medicines, they don't want to add another one, and their risk may not be that high. So it's kind of patient dependent. With rituximab, now that person is at high risk, so that would be greater than 10%. And so the recommendation is to treat those, prophylax those people.
So, the topic here is the reactivation of it. As we talk about, people with HIV who are on tenofovir, they're already getting prophylaxis in this case. But if they're not on an anti-HBV active antiretroviral, you have to think about prophylaxis if they're getting treatment with a immunosuppressive, which is, something that I think increasingly we're using tenofovir sparing regimens, and I think that's something to think about. Juhi, will his Hep C reactivate?
No, I think it looks like he's cleared. His RNA is negative, so I'm not worried about that.
Yeah, that question comes up, but Hep C we get to cure. It's nice and simple, not complicated like B. So that's why we're not doing any case discussions of Hep C. It's just simple. C virus, treat virus, cure it, move on. So that's that one you don't have to worry about. Any other comments about prophylaxis? The fear is that if the Hep B were to reactivate, you could have a very serious and in some cases life-threatening flare of hepatitis. And we've certainly seen that. Any other thoughts on the prophylaxis question? And would he benefit from immunization? I think from our previous discussion, I think some of you would immunize. Is that true?
Yeah, I would immunize. I guess one thing, because it's mentioned, so I think about it, is the fact that he has, he had some degree of liver disease prior to his hepatitis C treatment. And then what we tend to believe is, he was treated, several years ago. And so, what's the condition of his liver now? And not that that is always a major factor in this decision, but certainly someone that comes in with more liver disease, you worry about if there were reactivation, it could have a much bigger impact if they have a background of significant liver fibrosis. So, and again, this is not someone, he had stage 2. It may even be, if we did a fiber scan on him today, it may be even much less disease that we're seeing. But I do sometimes, worry about people with fatty liver, steatohepatitis, what other variables sometimes in this group because of just the idea their liver is already potentially primed. And then, I would vaccinate this individual, but I think sometimes these are difficult cases when it's not as clean, because we are seeing increasing variability in the medications that are being used, these different immune modulatory drugs, and sometimes it's not clear what category they fit in. So it helps to phone a friend, because I find that sometimes these decisions are not very clean.
Yeah, it's complicated, and they keep inventing new medications that suppress the immune system in different pathways, and sometimes the data is not there yet on the risk of reactivation for these. So it's a really good point. I kind of take a when in doubt offer prophylaxis. So Liz asked a good question. You've got sort of two choices: tenofovir, TDF, which is generic and relatively inexpensive. Tenofovir, which when you use for Hep B is branded and quite expensive. It's not part of a combination pill. And then you've got entecavir, which is also generic and pretty cheap. Lee, how do you choose between when to use entecavir, I guess is the question.
So entecavir is a perfectly good option for prophylaxis here, especially with cost consideration. I would also look at what some of their other risk factors are for say metabolic bone disease or their renal function as well. And I would probably select entecavir over TDF if they had any risk factors there. But otherwise, tenofovir, TDF, or entecavir are perfectly acceptable options.
I'll come out. One thing about entecavir is it has to be taken on an empty stomach 2 hours before or 2 hours after a meal. For some patients, that's actually somewhat challenging. But I will say with a good RX card, you can get a year's worth of entecavir for about $150. So it's relatively inexpensive. With a good RX card, it's not bad at all. Same with TDF. You can get to a price of about $90 for 6 months, or the $150 for about a full year supply. TAF is much more expensive for Hep B.
Yeah, so I agree. I would probably err on the side of using the entecavir just because it is so inexpensive, and if someone can take it, around the restrictions, and there's really no side effects. Patients that I have on it really have no side effects from it. The other thing I'll just add about this case also is that I didn't see it at first, but this hepatitis B testing was from 2017. And so certainly I would retest the person, at this point, since, now it's 7 years later, before making any decisions. One of the reasons is we know that when people have both hepatitis B and hepatitis C co-infection, usually the hepatitis C dominates. And so when the hepatitis C goes away, sometimes their hepatitis B will actually reactivate. So it is possible that this person is now surface antigen positive.
That's a great point. And I'm going to jump ahead because I did want to talk about, just so that everyone's aware, that there's now so we've been doing this in people with HIV for a long time, testing everybody at entry into the Bartlett clinic or the HIV practice. But the CDC did recommend that every person get tested for Hep B, every adult over 18 years or older. And there is this triple panel that's available. And it's going to identify people who are S antigen positive, but also those core antibody positive people. And the rationale was to identify these people at risk for reactivation. I will say, though, it does create a lot of discussion about the pattern you get. So maybe I just asked the group, what do you tell people who are core antibody positive, and they say, what do you mean I had hepatitis, or what does this mean? They're S antigen negative, core positive, and S antibody positive or negative. But what do you tell them about that? Because I have had that experience where people get referred because they're really not comfortable with this result and having what's known as resolved Hep B. So what are you telling people? Well, I saw Juhi come off mute. That might have been accidental, but
I'm so sorry. I didn't mute, to be honest. I usually tell people it's like, it could be a few different scenarios. One could be obviously false positive. The other one could be, you had Hep B in the past, but didn't form immunity. You didn't mount a response, an antibody response, or you could have some subclinical Hep B, in which case we should get a Hep B DNA. So the first thing I tell them is we just have to make sure this is not active infection and get a DNA. And if that's negative, then I proceed to vaccinate, to make sure they get immunity. But that's kind of how most people haven't had too many problems with that explanation. They just want to make sure they don't have active infection. I think that's what everyone gets freaked out about, because there's so many different things they see on the test results saying abnormal. So pretty step by step. I think everyone can handle that.
Any other thoughts of that? Now, is this, Chloe, I think you had worked with the EPIC team to get them to fire a BPA, a best practice alert. I haven't seen that come up. Is it operation?
So so there's two things that I did. One was to get a BPA, and that's gonna go to, as far as I know, that hasn't, even though it was like a year ago that they approved it, that hasn't been activated yet because, I don't know, technical reasons. Last time I talked to them a couple months ago. But that would only be, so you would only get that for a patient if they didn't have hepatitis B screening done. So Mark, you may not have seen it even if it were active, because probably most of your patients have had the hepatitis B screening. The second thing that we did in parallel was to actually get the Epic people to get a test code and for this triple virus screening panel. So now you can, if you like remembering numbers, you can remember the lab test number that's there. Or if you just type into Epic either HPV screening or hepatitis B screening, then this panel will come up and you don't have to do each one individually. It was, very hard to actually find, believe it or not, that total core antibody in Epic. And so we thought we'd make it easier for people to just get the screening done by having this test code. So hopefully people will use it and make their lives easier instead of having to find each individual one. Now, of course, if your patient's going to LabCorp request, this panel doesn't exist. It's only for people who are getting it done at Hopkins.
That's great. And just to make the point that everyone with HIV, as they're presenting, let's say, new diagnosis, should have this triple panel done as well. So that's been a recommendation for a lot longer.
Hey, Chloe, the inpatient hepatitis panel that they ordered that has Hep A, B, C, does that have these three in there? No.
No, that's been there for a long time. That's meant for, because it's inpatient, it's meant to test for acute hepatitis. So that has the IgM, hepatitis A, and surface antigen. I think it has core IgM actually. I don't think it has total core.
It has core IgM, yeah.
So it's meant to be an acute hepatitis panel, which is different.
Yeah, that panel is a bit vexing because the hepatitis A antibody IgM just means it's not acute. It doesn't tell you if they need the vaccine or if they're immune. That's the total Hep A. And it has Hep C antibody, but people with acute Hep C can be antibody negative. So you still, it doesn't quite cover. It gives you the sense you've covered A, B, and C, but it doesn't quite do that. Anyway. Other comments on the recommendations from the CDC on the triple panel screening, which are relatively new so now you've got a universal screening recommendation for HIV, Hep C, and Hep B. And Hep B was the last to join that sort of universal recommendation. So let me go on. I know we're running short on time. And let's see. So this is a person with long-standing HIV and hepatitis B. We'll try to squeeze one more case. He's on tenofovir. He's got the panel below, S antigen positive. His S antigen quant is 25. His liver is in great shape. There's been discussion about his kidney health, let's say, and some discussion about changing a regimen that doesn't include tenofovir. And this comes up particularly if the serum creatinine goes up elevated. So I guess what are the options here to treat Hep B, or how we approach that? And does that low surface antigen suggest that maybe you could stop treatment? And maybe I'll start with Dave. You alluded to a low S antigen and sort of needing treatment or not. And that's a pretty low number.
Yeah, it's a low number. I think that, you can, it's going to sound like a dodge, but this is one of these ones where you can counsel the person that there are two options. One here is to stay on Hep B active regimen, and the other one is to come off and to take your chances, which involves, and I emphasize this, frequent monitoring, a lot of blood testing every month, having to come back. And so for some people, that's a deal breaker on its own. Like, oh no, you mean I have to bother with blood draws every month? And I say, yeah, then that stops the discussion. But so I think that I haven't seen data in HIV. So I don't really know what the statistics are. I think 25 I would say this is sort of going to end up being not a high confidence stop. Because of the HIV and because 25 is not less than 10. So, Chloe, do you know, or Mark, does somebody know HIV?
As far as I know, there are no data in HIV, and that's what I would have said. And that's, in people without HIV, I think his risk is pretty low at 25, but I haven't seen any data in HIV. So I would prefer keeping him on a tenofovir-based regimen.
So the consensus would be that he needs to stay on some form of Hep B treatment and not take him off because he is still S antigen positive. We've got like 1 minute left, but what about entecavir here? And Chloe, I'll ask anyone, what about switching him to, say, a daily entecavir plus long-acting injectable? That would be okay?
Yeah, I think that would be fine.
Yeah. And then, so I'm going to stop there and I'll stop sharing my screen just in the interest of time. And certainly want to thank our panel for walking through these cases. And the thing with Hep B that I know is that we never really address all the different nuances because there's so many different variations of the virus human immune system interaction and so many different twists to it. And then with HIV and tenofovir-containing antiviral therapy, it gets even more complicated. So we wanted to try to touch through some of this and maybe just reinforce a couple of themes about making sure we're vaccinating people, screening people, vaccinating, and then those who are Hep B positive, making sure that we're getting ultrasounds and AFPs every 6 months for cancer screening. And the last thing I'll say is a plug for clinical trials. The ACTG has a hepatitis transformative sciences group, which has the hepatitis vaccine study was conducted at Hopkins. There's currently a study for co-infected patients with an active drug that we're working on. Juhi is leading that one, and there's more coming. So stay tuned. And I'll pause there. I'll turn it back over to Eileen, but I really want to thank everyone and thanks for all your attention and great comments in the chat. And thank our panel for being on the spot.
Well, thank you so much to all of you. This was really fantastic. I do have one question I'd like to sneak in the last 30 seconds that are gone, just in terms of with the Hep B isolated infection, which is not something I deal with very often. In starting therapy, it seems like you're back a little bit more in the kind of where we were stewarding more in terms of the risks of stopping medications and rebound hepatitis. And do you do an adherence assessment for patients? I no longer really do that for HIV because, you just sort of work through it, but I don't have a rebound hepatitis hanging over me. So just wondering if in the last seconds that are already gone, if anybody could bite on that one.
So is your question, Eileen, do we ask about?
Yeah.
Is there more infected? Do we ask about adherence? Is that your question?
Right. Are you more hesitant to start therapy because of the risk of, with HIV, even if I think someone's going to be non-adherent, I try. I mean, I have very little low threshold. And granted, those patients, some of them also have Hep B, so I guess I'm not really that worried about it. But I just wanted to know what the needle is on adherence for Hep B therapy in isolated infection.
Yeah, I talk to my patients about the need to stay on treatment and that their hepatitis B can come back and it can lead to severe liver disease. But it doesn't keep me from starting people on treatment.
I'd say it's one of the reasons why that there's some lack of enthusiasm when there's no data that treatment is going to help that person prevent cancer or long-term risk. It's one of the reasons to hesitate is that, I've had many patients who stopped their medicine. They just didn't get refills and they were fine. But the literature is full of people who stopped medication and they weren't fine. They developed fulminant or severe hepatitis B. So it does come up when the treatment indications are kind of squishy, and that's that gray zone that we talked about. I don't know, Dave, you got a comment on that?
No, I agree completely. I think it's one of the reasons. It's my most common reason that the person themselves will say, "No, I'll wait," because if you say you start for the foreseeable future, like years and years and years, you'll need to take this. And that's a really important message because it's not urgent. It's not urgent. And so you have to prepare them. Like otherwise it's not fair to them to get them started in the 6 months to have them be like, now I want off. And then you're like, okay, you have to get monthly monitoring. And so I think that's a great point, Eileen.
Well, thank you so much, and thanks for the extra question that I didn't pay for in my hour. So, we will all be continuing to bother all of you with email questions in the future. Thank you so much. This was really fantastic. Have a great weekend, everybody.
Thanks, everyone. Bye.